3A session. At first, I would like to invite our both chairs. At first, I would like to invite our chair, Brigadier General Professor M. Kamrul Hassan sir. I would like to invite sir to our stage. Brigadier General Professor M. Kamrul Hassan sir is Advisor Specialist of Psychiatry in Combined Military Hospital, CMH Dhaka, Bangladesh. He is an Executive Committee member of Bangladesh Association of Psychiatrists, BAP. Please make a big hand for sir. Our next chair, Professor MMA Salauddin Kausar Biplov sir. I would like to invite sir on our stage. Professor MMA Salauddin Kausar Biplov sir is working in the Department of Psychiatry, Bangabandhu Sheikh Mujib Medical University, BSMMU, Dhaka, Bangladesh. He was a section member of Mass Media and Mental Section of the World Psychiatric Association, WPA. He is the founder and coordinator of Polypsychiatric Sex Clinic PSC of the Department of Psychiatry, BSMMU, Dhaka. Please make a big hand for our sir. In this session, our four young, promising, and elegant presenter will present their presentation. But before we starting our presentation, I have to say something about rules and regulation. Each presenter will get 12 minutes. After 9 minutes, first bell will ring. After 11 minutes, second bell will ring. And at the end of 12 minutes, automatically the screen will be off. If any of our audience like to ask any question, our volunteers will provide pen and papers to them. After the presentation of our four presenters, the question and answer session will be occurred and discussion session as well. At last, I just want to say we are very much strict about our time. Now, I am going to start our session, and our first presenter is Dr. Muhammad Saeed Enam sir. Dr. Muhammad Saeed Enam sir is currently working as Assistant Professor in Sylhet M.A.G. Osmani Medical College. Sir has completed his MBBS degree from Dhaka Medical College. He is a very well-known face in our psychiatry department and as well as very much efficient presenter in psychiatric institutional level. I would like to invite Dr. Muhammad Saeed Enam sir to come on dais and present his presentation.
Respected chairperson, my teachers, colleague, and dear student, good afternoon. I am presenting my oral presentation. Before that, welcome to everybody. The title of my presentation, Surviving 50 Years with Shrapnel Within the Brain. It's a case history. Introduction: traumatic brain injury during the war by shrapnel or bullet is lethal and life-threatening. The mortality rate from traumatic brain injury is more than 90%. Mrs. N of Bangladesh is an exceptional and one of the luckiest women of the world in 21st century. She is a war victim and has living with shrapnel within her brain for the last 50 years. On April 20, 1971, during the Revolution War of Bangladesh, the opposition military force launched several mortar shell attacks on Mrs. N village and one of the shell exploded in their backyard. A few of Mrs. N family members died on the spot while she was seriously injured. At that time, a piece of shrapnel penetrated her body and head. She lost her consciousness and was later treated nearby at the war hospital as best as possible. Mrs. N Begum is now 70 years old, is still carrying those fragments of violence unlaced within her skull. In the last 50 years, shrapnel continued to travel through the deeper structure of her brain and created a big cyst within her brain. This is termed as encephaloclastic porencephaly. She has been living with several neurological and psychiatric complications for the last 50 years. These symptoms include weakness of the left upper and lower limb, forgetfulness, headache, dizziness, and occasionally disorientation, convulsion, hearing of unknown voices, fearfulness, and also cognitive deficit. As her condition worsened, her family members took her to me for better treatment. Mrs. N and her family members were unaware of the head injury. Even they have no medical documents about the past pathetic incident. Considering her traumatic blast injury, an X-ray skull was advised. Surprisingly, it showed a piece of shrapnel lodges within her skull. Furthermore, to confirm the shrapnel and other depth of injury, she was advised to have an urgent CT scan of the brain. The CT scan showed shrapnel within her brain created a big encephaloclastic cyst. Cyst occupies her entire right parietal and frontal lobe. Shrapnel gradually affected the functioning of her brain for the last 50 years. This is the bullet. This is the picture of encephaloclastic porencephaly affecting 1/3 of her brain. Medication advised to control her psychotic symptoms, risperidone 2 mg and other supportive medication were advised. She was also referred to neurosurgeon of the National Institute of Neuroscience for further management. After a general and systemic examination, the Board of Neurosurgeon of National Institute of Neuroscience, Dhaka, decided to remove the shrapnel, but Mrs. N and her family denied to undergo operation. Here, brief discussion I would like to say. The discovery of unsuspected intracerebral shrapnel or bullet years after the injury has rarely been reported. Shrapnel within the brain for a long time created encephaloclastic porencephaly. The location of penetrating cerebral wounds varied from study to study. The main location were frontal, parietal, temporal. The seriousness of injury depends on several factors. These are GCS score, their extension, location, cerebral injuries, and management. The GCS score is very important. A lower GCS score predicts a poor outcome and higher is better. Other factors associated with poor outcome are multilobar injury, intraventricular hemorrhage, dominant hemispheric injury. After recovery from pulmonary injury, most patients are asymptomatic. The shrapnel gradually become encased in fibrous tissue and considered inert. Rarely, however, shrapnel causes harm in the long term, either in the form of systemic damage because of shrapnel degradation or because of local foreign body reaction. Lead shrapnel, usually retained in soft tissue, can cause plumbism. Shrapnel wounds should be treated on case-by-case basis. The 4 Cs of muscle viability, color, consistency, capacity to bleed, and contractility are used to assess. In acute phase, life-saving procedures are performed to hemodynamically stabilize the patient. The retained fragments are usually benign, and the surgeon should not attempt to remove it. Now I conclude my session. Conclusion: delayed recognition of cerebral foreign body is very rare in the world. In this case, the longest time of shrapnel within the human brain, accompanied by psychotic symptoms, is presented and discussed. Surviving 50 years with shrapnel within the brain is the rarest condition in medical science. This is the references of my case study. This case also I presented Royal College of Psychiatrists England Edinburgh conference this year, and this case also published in Royal College of Psychiatrists England special book, also published in British Journal of Psychiatry. Thank you, everybody.
Thank you very much, Dr. Mohammad Saidinam sir, for your nice delivery. It was such a nice session. Now I would like to invite our next presenter. Our next presenter is Dr. Tumpa Indrani Ghosh. Dr. Tumpa Indrani Ghosh is a child and adolescent psychiatrist. As we all know, she is very much promising and young, elegant child and adolescent psychiatrist who is currently working as a registrar at National Institute of Mental Health, Dhaka. I would like to invite Dr. Tumpa Indrani Ghosh to come on stage and deliver her presentation.
I am very much delighted to present my case report, pediatric obsessive compulsive disorder. The main symptom was mobile stealing, and it is a rare presentation of pediatric obsessive compulsive disorder. With the permission of my chairs, I am going to present my case. Tahsan, I have used a pseudonym, who was an adolescent boy and presented with stealing or pick up mobile phone, and for this he faced several social harassment. And finally, we diagnosed him as obsessive compulsive disorder after psychiatric assessment, and he was treated with fluoxetine along with psychological management, exposure and response prevention. According to DSM-5, we diagnose his obsessive compulsive disorder on the basis of presentation of symptom obsession, compulsion, or both, and these are very time consuming, usually more than 1 hour. And in different study reports, we found that the main symptom among the children and adolescent group, fear or contamination, succeeded by pathological doubt, somatic symptom, and checking rituals. Multiple obsession and compulsion present in majority of the patient, and the symptom obsession are more than compulsion. The prevalence of OCD among Bangladeshi children and adolescents found 1% to 2%, and sometimes among the pediatric age group present in an unusual way that their assessment and diagnosis become so difficult, and for this they face legal issues or multiple consultation in different specialties. And this case report was published, and the authors, Dr. Monirul Islam and my respected teachers, Professor MSI Mollik sir, to give permission to present this case. The main symptom of Tahsan was urge to pick up mobile phone and tendency to complete every work in an unusually perfect way, and subsequently he developed repeated checking behavior and finally irritability for the last 2 years. Tahsan was quietly normal 2 years back, and then gradually he developed to practice some behavior significantly after following a death of his uncle, and he described his symptom and urged to repeat certain action until complete perfectly. And subsequently he developed repeated urges of certain motor act such as socially embarrassing ones and specifically urge to slap others. And he was unable, and these symptoms make him very much distressed to leave the house without lengthy and repetitive checking of his school bag, door locks, water taps and electronic switches. His mother gave him a mobile or cell phone so that she can contact him when he was outside the home. He felt very much distressed when his pocket was empty and there was no mobile phone. And he started to go to mobile shop, repair the shop and fill his pocket. He also started wearing shirts without pocket. And he stole mobile phone total 6 times, got caught every time, and the last time legal action was taken against him. Other relevant histories found that Tahassan was a child of non-consanguineous parents, and significant mental illness was found in his family history. His paternal uncle suffered from psychotic illness. All the birth and early developmental milestones were uneventful, and his academic performance was good. Tahassan never took any substance, and he had no psychiatric disorder or any developmental disorder, and his mood predominantly was euthymic. But he passed his COVID-19 pandemic period learning to drive a motorcycle and Facebooking. During mental state examination on first visit, it was found that he had obsessive impulsive and thought of doubt with theme of the need for symmetry. And he also had compulsion in the form of checking, specifically ordering or arranging things. No psychotic symptoms such as hallucination, delusion was present. His intelligence was average. And during the first visit, we used children Hill-Brown obsessive compulsive scale, and the score found subsequently as total score was 31. Among these, obsession was 14 and compulsion was more than obsession, 17. These diagnoses were we considered as differential diagnoses such as obsessive compulsive disorder, kleptomania, conduct disorder and normal stealing. He was not a case of kleptomania as he was predominantly distressed before the act and there was no pleasure or gratification after the act. And Tahassan has no deceitfulness, aggression or any serious law-breaking behavior. And so conduct disorder and kleptomania were excluded. In real theft, stealing occurs due to material value or personal benefit, and his family status was good. From history, examination and investigation, Tahassan had been suffering from, and our final diagnosis was obsessive compulsive disorder with fear inside. And we planned treatment on the basis of his symptoms. Main problematic symptoms were urged to pick up mobile phone and want to complete every work in a perfect way. And subsequently, for this symptom, significant educational and social problems were developed. And our goal were not to picking up phone and shop, reduction of his repetitive checking and perfectionist behavior, and improvement of his quality of life. So we gave treatment on child focus, school focus, family focus, because school and family focus is very mainstream part of the treatment of a child and adolescent age group. And at first in child focus, we gave proper explanation and support and psychological intervention. We used exposure and response prevention. This is the very important psychological treatment among pediatric OCD group. And we gave medication such as capsule fluoxetine initially started with 20 milligram and gradually titrated to 40 milligram. And family focus, proper psychoeducation and family counseling were given. And as he was a adolescent age, so mother worked as a co-therapist at his home. And a school focus, as he suffered from various legal issues, so liaison with school authority by giving a letter describing his proper symptoms intervention, and social focus gave a letter to the police station and chairman of the union council describing the main psychiatric problem that Tahasan had been suffered. And to follow up fortnightly for the first 3 months, initial increment of anxiety and restlessness due to medication, and that was successfully managed by short-term use of clonazepam. And initial improvement was achieved after 1 month. And children Yale Brown obsessive compulsive scale Bangla version was 26, 21, and 11. Total score 21 obsession and 11 at the end of first, second, and third month, respectively, with regular ERP session along with 40 milligram fluoxetine. Children and adolescents are typically presented with contamination, fear of harm, and pediatric OCD occasionally present in such a way that does not fall into one of these themes. And Tahasan, biologically vulnerable as one of his paternal uncle has psychotic illness, and his authoritarian parenting figure, and the COVID-19 pandemic situation triggered his symptom. And though he has many bad factor, but he also has some protective factor such as supportive mother, good financial condition, and he achieved at school and very good, and he has average intelligence. So we expect that if he continues his current intervention accordingly, he will be able to lead a better life. And I want to acknowledge Dr. Ahsan Aziz Sharkar for helping me a lot to make my case report. Thank you.
Thank you very much, Dr. Tumpa Indrani Ghosh, for your nice and brilliant presentation. It's my pleasure to announce that this scientific session, oral presentation 3A, at Mohana Hall number 1, is sponsored by Beacon Pharmaceuticals. Thank you, Beacon Pharmaceuticals, for your sponsorship. Now I would like to invite our next presenter. Our next presenter is Sumaya Binte Jalil, who is currently working as an MD resident Phase B of Child and Adolescent Psychiatry in Bangabandhu Sheikh Mujib Medical University, Dhaka. As we all know, she has very much keen interest in research and other clinical practices. I would like to invite our future child and adolescent psychiatrist, young promising, Dr. Sumaya Binte Jalil, to deliver her presentation.
Thank you. Assalamu alaikum and a very good evening to you all. You already know about me. I'm Dr. Sumaya, Phase B resident, Child and Adolescent Psychiatry, Bangabandhu Sheikh Mujib Medical University. Today I'm going to present an original article titling Suicide in Bangla Movie and Drama, a Content Analysis. These are the list of authors of our article. This is the content I'm going to give a short description about. Now, we all know that suicide is a global public health problem that took near about 7 lakh people in 2019, and among them, 77 suicides happened in lower and middle income countries, just like Bangladesh. And you will be surprised to know that a psychological autopsy study conducted in Bangladesh showed that 91% of suicide had adverse life events before their death, whilst only 61% had psychiatric disorders, indicating social factors may have a larger impact on suicide when compared to clinical factors. Now, we all know that how this media depiction of suicide can affect real rates of suicide, because adequate available evidence suggests that there are basically two kinds of impacts that happens right after medial portrayal of suicide. That is Werther and Papageno effect. Werther effect is the copycat suicide that occurs when a suicide scene is portrayed in movies and drama that increases in if there is a bad portrayal. And Papageno effect is the alternate effect. That is the decreased number of suicide happens if there is appropriately portrayed suicide scene is there in the motion pictures. Now, how this cinema or motion pictures play an important role in case of real suicide rates in the society, because cinema depicts the contemporary culture, social norms, beliefs, and collectiveness through thoughts going for beyond the entertainment only, as it shapes mass perception, both with immediate effect, that is the distress and the release people feel right after seeing a suicide, and a long-term influence when the suicide remains as a semantic memory in the back of our mind. Now, a considerable amount of evidence cautions us that a sensational and explicit broadcasting of suicide in motion pictures can increase the risk of suicidal behavior in the general population. And we have to reanalyze that why suicide is public health issue in Bangladesh. It also has some multiple additional negative points like low suicide literacy, high stigma, religious and cultural practice, low quality suicide data, inadequate and sporadic prevention program. That in all this, because of all this, suicide prevention is still at the ground level. And therefore, responsible media reporting of suicide in the media and the motion pictures has been indicated as population level suicide prevention strategy. Now, as there was no studies have been noticed assessing the suicide depiction in Bangla movies and drama and its impact on the general population, therefore we aim to assess how suicidality has been depicted in Bangla movies and drama by scrutinizing their contents against socio-demographic checklist and WHO media guidelines. It's a narrative quantitative analysis of motion pictures containing suicidal behavior available in Bangla movie and drama. A search on YouTube, as it was readily available and easily researchable, was conducted by using the term suicide in Bangla movie and suicide in Bangla drama, both in Bangla and English, to identify movies. The search was performed between February and May 2022. Total 71 items consisting of 35 Bangla movie and 36 Bangla dramas were included. Without any ambiguity, the suicidal behavior were included. And in exclusion criteria, movies before our liberation war, that is 1971, movies involving war, movies involving suicidal bombing, movies involving physician-assisted suicide, these things, and Bangla language, another language movies that is in West Bengal were also excluded. So this is the three positive criteria and three negative criteria mentioned by WHO media guidelines, which were assessed against. Like in positive criteria, we have adequate information about help seeking for suicidal behavior, provision of facts and statistics on suicide, if it was given or not, and supportive information regarding coping with life stressors or suicidal behavior, whether they were mentioned or not. And among the negative criteria WHO has mentioned, language normalizing suicide or presenting it as a way out of the problem, description of methods, and details of the location of the suicidal behavior, if it's present or not. Now, these are the results. As you can see, there were more number of attempts in dramas, around 66%, and more in completed suicide in movies, that's about 60%. Mostly it's the lead actor who is committing the attempts, that is 55%, and most important methods were hanging, jumping in front of the train, poisoning along with cutting the wrist, and jumping from the bridge, etc. Most common place is the home, and next to that there is public place, and then there is bridge and other multiple places involved. Now, female were the ones seen most attempting suicide in, attempting in, that is 68%, and then the male, mostly it's the middle adult, mostly it's them, that show their graduates and their homemaker. There are unmarried people more from the middle class. And among the risk factor, it was seen that marital problem is the top risk factors shown in the motion pictures. And then there is extramarital affair, family conflict, frustration, unemployment, sexual harassments are also there as a risk factor, and also addiction. Now, these are the quality assessment of the reporting. It is, you will be not be surprised when you see that there is minimal portrayal of the protective factors and maximum portrayal of the negative factors, like complete portrayal is there in 45% cases, and almost 100% of the samples had full description of the location of the attempt and depiction of the attempt, which was prohibited in the guideline, and mental health message, providing information about where to seek help, educating the public about the facts of suicide, and reporting stories of how to cope. These were seen very minimally in the movies and drama. So, the studies clearly revealed a poor quality when compared to the WHO media guidelines of the suicide, with mentioning the name of the methods, place of suicide, and the depiction of suicide scenes in one hand. On the other hand, there are negligible attempts to educate the general population and prevent suicide. So, it is an important area to prioritize while formulating our national suicide prevention strategy. What does it imply? It indicates an extreme lack of awareness regarding the impact and guidelines of the depiction of suicide in motion pictures among the persons in the film industry, especially those behind the camera. Movie directors also depict suicide as per the social construct, while there is no monitoring and controlling agency. So, the majority of the risk factors are related to the pre- and extramarital relationship issues, while psychiatric disorder and drug abuse covers only minor proportions. So, like any other study, this study also has some strength and limitation, as the samples were purposefully chosen, so there was a possibility of selection bias is there, as generalization of the study result is restricted, and the incidence could not be calculated, and the socio-demographic variables based on the subjective judgment of the authors, which may be a potential source of bias. But this kind of study is one of its own, enduring the social build-up and showing this kind of portrayal of movies seen against the WHO guidelines. This kind of study was not done before in Bangladesh, also in the Southeast Asia. So what is the highlight of this whole presentation and the whole article is that the efforts are warranted to improve this status quo, as well as utilize this massive platform of motion camera by spreading positive mental health message, social factors of suicide, and magnifying the related protective factors are needed. What are the future directions? Of course, creating awareness among the director, producer, artists of the motion pictures, and academics of cinematography should be the primary initiative to increase the rate of potentially helpful characteristics, as well as to reduce the potentially harmful characteristics of WHO media guideline, suicide prevention via special booklet. The entertainment media should be properly used to nudge attitude and modify practice, as it has a mass audience through proper collaboration between media and mental health professionals. So these are the author's information. References are available on request. Thank you so much for patient hearing, and I'd like to thank the organizers of ICP to giving me the opportunity to present, and also my chairs. Thank you so much.
Thank you very much, Dr. Sumaya Binte Jalil, for your lively and nice presentation. I would like to invite our next presenter, and he will be our last presenter for this session. But before I like to invite him, I just want to say, a doctor is a student till his death. Dear audience, with your patience, you are now listening our every presentation very carefully. I have watched it, and I just want to thank you very much to help us. Now I would like to invite Dr. Muhammad Arifuzzaman, who is working as an MD resident Phase B of Psychiatry in National Institute of Mental Health, Dhaka, Bangladesh. As we all know, he is very much hardworking and young, promising future psychiatrist he will be. I would like to invite Dr. Muhammad Arifuzzaman to present his presentation.
Honorable chairs, distinguished guests, and respected audience. It is really a great opportunity for me to present in this big stage. I am a PhD resident of psychiatry of NIMH, Dhaka, and today I am going to present a case report. So this case report was published in Bangladesh Journal of Psychiatry, volume 35, issue 2, in this year, which this journal is the official journal of Bangladesh Association of Psychiatrists, and the title was Management Difficulties in a Patient with Obsessive Compulsive Personality Disorder, Attention on Therapeutic Relationship. My co-authors were Dr. Mekhala Sarkar, who is the Associate Professor of Psychiatry of NIMH, and Dr. Muntasir Maruf, who is the Assistant Professor of Psychiatry Department of NIMH. And actually, why I am here today? One is to present, to take the challenge in front of you. Another one is to show my gratefulness to my mentors who helped me to grow. In this case, Dr. Mekhala Sarkar ma'am actually helped me from the beginning to the end, from selection of the case to writing reports and even the publication. So it is really a big stage for me to show my gratefulness to her. As the title, as you see, it was a case of obsessive compulsive personality disorder, and we focused on the management part, the challenges we faced to treat the case. But we saw the highlight was therapeutic relationship. An effective doctor-patient relationship was very important in our case to actually create a gateway to treat the patient. And about particulars, he was a 35 years old male, unmarried. This is important because in our culture, it is not usual to see a person unmarried at the age of 35 years. And he was an efficient telecommunication engineer. In his last job, he was very active and was promising, but he was then unemployed. This is important for this case, why he was unemployed. That's about symptomatology. He was overconscientious, very inflexible about his lifestyle and was perfectionist. And additionally, he had problems delegating tasks with others. He could not go with the group works, and had problem with intimacy, though he loved her parents and others, but he avoided intimate relationships and gradually was living solitary lifestyle. So from those point of view, the diagnosis was made as obsessive compulsive personality disorder according to DSM-5. So what was the main problems in his life? Was maladjustment. He could not adjust with his job, with his family and others. What happened with his family was that he had some problems with the diet, a very restrictive dietary style, and at the same time, he was problem with the marriage. He rejected different proposals from different style or different culture or different levels, but rejected without any sufficient reason, with some reasons regarding his inflexibility and perfectionism. And also, he had history of frequent job switch. And as I already mentioned, that his previous job was very handsome salary job. But due to some overconscientious matters, he left the job. And gradually, he was socially isolated. He kept himself socially isolated due to some problems. Here, I just try to show that what happened to him, the OCPD symptoms leads to adjustment problems and eventually to life difficulties. So what are the challenges we faced treating this case? First one was to build up a therapeutic relationship. He thought himself as smarter than us, and at the same time, he was not actually agreed to take changes. And that's why to build up a relationship was our first challenge in that case. And also, as we know that OCPD is an ego dystonic disorder, so there was no reason for him to accept treatment. Another important was very important for him. Avoidance was his prime coping strategy. Whenever he faced some problems with a person or a situation, he avoided, and that's why he was gradually socially isolated. And the next one, restoring dignity, was also important because it was his concern. As we saw that he was forcefully admitted there, and it was a big harassment for him. That's why restoring his dignity after the treatment or at some stage of treatment was another challenge. And family factor was also a big factor in this particular case because his family was very irritating. His lifestyle was restricted, but still was not harmful for him. But the family members were very much disturbing for him in those regards, and that's why the family discords or family disharmony was present. And the final challenge we noted here is the follow-ups. Maintaining follow-up in this case was thought to be difficult and was finally proved to be difficult. I want to show you later on. So what we did for this patient, some pharmacological treatments we offered, like fluvoxamine. I found the efficacy of fluvoxamine for OCPD in some studies, and also some low-dose antipsychotics to reduce his agitation as he was admitted without his will. But the mainstay of treatment was psychological, and he had some problems. He had reduced problem-solving ability, and that's why we tried to offer him problem-solving ability, to improve his problem-solving ability. But right at this moment, I want to say that building an effective therapeutic relationship was the problem. And we needed more time, I will show you in a graph later on, to build up this therapeutic relationship. When we were able to build that one, gradually he accepted changes, and then we were able to offer those treatment options for him. Family counseling was really important because we wanted to reduce the family disturbance and to keep him at least without some disturbance free. We targeted the coping from avoidance to confrontation, to logically confront somebody without avoiding him. And it was actually an improvement in that case. I will show you later. And there were some cognitive errors, and we tried to solve them, but we couldn't get enough time to give more sessions. So now, this is a imaginary graph actually created by me, an arbitrary one, and here just I wanted to show what happened. In the first few days in this graph, we see that there is less improvement. The improvements was in terms of reduction of agitation, nothing more than that one. But right at this point, we were able to build a relationship. And when we were able to build that one, gradually, he accepted those changes. He was in the treatment procedure, and his negative belief or negative attitude towards family members were also reduced, and he gradually accepted confrontation as a coping strategy. So we were not sure at the beginning or at the initial phase actually how much he would go, but later on we got some real improvement in this case. So now why I am presenting this case here? OCPD is a very prevalent personality disorder. According to DSM-5, it is 2.1 to 7.9. But the problem is clinical recognition is very low. As it is ego dyssyntonic, they don't love to come to the clinicians. And that's why it is also a point for me to present the case, and it causes significant functional impairment. In our case, it caused huge disturbance in his interpersonal relationship status, and also another important area is his potentiality or his productivity. And the treatment options regarding OCPD is also not much well established. There are some medications and psychotherapies, but they are not that conclusive. So that's why I also presented the case. So the focus is on necessity of more research. Actually, the end message from my little brain is that we need to do more research regarding the treatment options, how to engage them in clinical point of view, and to improve their functioning. Those are the references. So my end message of this case report. First, as I already said, it is significantly prevalent, but the clinical attention is very low. They are very difficult to engage in treatment. And therapeutic relationship was, and highlighting point was pivotal or crucial in managing that case. So we need more research regarding those things to at least improve treatment, improve some treatment strategy, some improved treatment strategy to actually provide better option for OCPD. Because if we are able to provide some options, they will lead a good life, a productive life, an interpersonally active life. Thank you so much, and thanks to the authority to provide me the chance to present here. Assalamu alaikum.
Thank you very much, Dr. Muhammad Arifuzzaman, for your nice and lovely delivery. Now this is the time for discussion and question answer session. I would like to request our volunteers to collect written questions from our audiences, from our respected audiences, if there any. Our volunteers have provided pen and papers to everyone if they need it. I would like to request our volunteers to collect the questions. Due to shortage of time, we will take few questions, and after the questions, we will go to our ending session. First question to our first presenter, Dr. Saidenam sir. Why the bullet in the brain was not diagnosed early in the treatment? Was the concerned doctor responsible for this mistake? I would like to invite our first presenter, Saidenam sir. I would like to request our volunteer to provide hand mic. To our first presenter, respected.
Very nice question. This question I have faced from England and Australia also. যে কেন এই বুলেট এত দেরি লাগলো ডায়াগনোসিস করতে, 50 বছর লেগে গেল? এটা আসলে বিষয়টা হচ্ছে তার মাঝে মধ্যে মাথা ব্যথা হতো এবং কনভালশন হতো, এটা কম হতো আর কি। তো এই সাবকন্টিনেন্টে আরও কিছু মানসিক সমস্যা হতো, যেমন ভুলে যেতেন বা সাইকোসিস। তো এই সাবকন্টিনেন্টে এই সিমটমগুলা খুব বেশি অবহেলিত, অর্থাৎ মানসিক রোগ অবহেলিত। তো আত্মীয় স্বজন মনে করতেন যে এটা হয়তো আমাদের সিলেট অঞ্চলে উপরি রোগ বলে, উপরি ধরেছে, বাতাস ধরেছে, জিনে ধরেছে। তো এই করতে করতেই তার 50টি বছর গিয়েছে। আর আরেকটি প্রশ্ন হয়তো সবার মনে আসতে পারে যে তিনি কিভাবে ভুলে গেলেন তার ব্রেনের ভিতরে যে বুলেট আছে বা এত বড় একটা ইনজুরি। এটা হলো তিনি যখন আঘাতপ্রাপ্ত হন প্রায় 15 ডেজ তিনি অজ্ঞান ছিলেন এবং অনেক সদস্য পরিবারের মারা গিয়েছেন। আর এরপরে যেহেতু ওয়ার একটা ক্রুশিয়াল কন্ডিশন, ডকুমেন্টস রাখা যায়নি। তিনি দেশে চলে আসছেন পার্শ্ববর্তী দেশ থেকে, আসার পরে সমস্ত ডকুমেন্টস হারিয়ে যায় এবং ওই টাইমটা স্পেসিফিক ইনজুর্ড অ্যান্ড পোস্ট ইনজুর্ড তার মেমোরি থেকে পুরো লস হয়ে গিয়েছিল। আরেকটা হয়তো জানতে পারেন যে আমি কিভাবে বুলেটটা ইয়ে করলাম। তো আমাকে তিনি বলতেছিলেন যে আমি দীর্ঘ 50 বছর থেকে আমার মাথা ব্যথা এবং মাথা ঘোরায় পড়ে যায় ইত্যাদি ইত্যাদি। তো আমি জিজ্ঞেস করছিলাম মাথায় কি কোনো আঘাত পেয়েছিল কিনা। তো তিনি বললেন যে আমার আত্মীয়স্বজন বলেন আমি নাকি যুদ্ধের সময় আহত হয়েছি। তো জিজ্ঞেস করলাম যে কি কোথায় আঘাত পেলেন। তো তিনি বললেন যে আমার মাথায় আঘাত বা হাতে আঘাত। তো আমি তাকে কাছে টেনে মাথাটা একটু হাত বুলাই যে দেখি মাথায় কোথায় আঘাত। তো দেখলাম যে একটি জায়গায়, মাথার একটি জায়গায় ওখানে বোন নেই, হাড্ডিটা নেই, একদম নরম। তো আমি বললাম যে এই জায়গাটা নরম কেন বা এখানে হাড্ডি নেই কেন। তো তিনি বললেন যে আমি এটা জানি না। তো সাথে সাথে আমি এটা এক্সরে করিয়ে নেই এবং এই মানে রহস্যময় বিষয়টা সমাধান হয় আর কি। ধন্যবাদ সবাইকে।
Thank you very much, sir, for your nice explanation. Due to shortage of time, we cannot take any questions from our respected audiences.
Hassan, I have another question to Dr. Inam, if I get time.
Yes, sir, obviously.
আচ্ছা, আমার কোশ্চেনটা হলো আপনি যখন এই জিনিসটা মানে রেডি করলেন কেস হিসেবে, তো প্রথম এটা পাবলিশড হলো রয়্যাল কলেজের একটা জার্নালে, আবার সেটা ব্রিটিশ জার্নাল অফ সাইকিয়াট্রিতে পাবলিশ। তো দুই জায়গায় আসলে একটা আর্টিকেল কি আসলে পাবলিশ করা যায় কিনা, আর গেলে সেটা কিভাবে, এবং আমাদের যদি যারা স্টুডেন্ট আছে বা আমরা যারা পাবলিশ করতে চাই তারা এই অ্যাডভান্টেজটা কিভাবে নিতে পারি?
স্যার, রয়্যাল কলেজের যে সেমিনার বা কংগ্রেস হয় বা আমাদের যেটা হচ্ছে, তারা সেমিনার এবং কংগ্রেসের পরে তারা একটা বুকলেট, রিভিউ বুকলেট বের করে। তো ওইটাতে তারা আমার এই অ্যাবস্ট্রাক্টটা ছাপায়। আর আরেকটা আমি দেখলাম যে তাদের উইন্টার একটা ইয়ে আছে, উইন্টার এডিশন চাইল্ড অ্যান্ড অ্যাডোলেসেন্ট ফ্যাকাল্টির, ওইটাতে তারা আমার পুরো আর্টিকেলটা ছাপিয়ে দিয়েছে। এটা আমি জানতাম না। তো আমি একদিন সার্চ করলাম, আমার এটা নিয়ে আর্টিকেলটা মানে টাইটেল দিয়ে সার্চ করলাম, তো দেখলাম যে ওখানেও ছাপানো আছে। তো আমি তাদেরকে মেইল করলাম যে আপনারা যে আমার আর্টিকেলটা ছাপালেন, আমার তো অনুমতি নাই। তো ওনারা বললো এটা যেহেতু কংগ্রেসে এটা উপস্থাপন হয়েছে, কংগ্রেসের সাথে আমাদের একটা লিঙ্ক আছে যে আমরা যে কোনো ছাপাতে পারি, এই আর কি বিষয়টা।
তো ওইটা যখন ব্রিটিশ জার্নাল অফ সাইকিয়াট্রিতে আবার ছাপানো হলো, এটা একটা কনফ্লিক্ট তৈরি করবে না?
না, তাদের সাথে তাদের সব অ্যাবস্ট্রাক্ট তারা ছাপাতে পারে, এই ধরনের একটা শর্ত আছে তাদের, যে ছাপাতে পারবে তারা। এবং এটা শুধু এটাতেও না, আরো কয়েকটা জায়গায় ছাপানো আছে। মানে টাইটেল ক্লিক করলে দেখা যায় যে সবগুলো চলে আসে, যেমন নিউরোলজি, আমেরিকান একটা ইয়েতে, তারপরে ক্লুয়েটা, আরো কয়েকটা জায়গায় আর কি।
মাইকটা দেন না, একটু মাইক। এই যদি টাইম কম হয় আমাদেরকে জানাই।
কপিরাইটের ব্যাপার আছে আমার মনে হয় কোনো একটা জায়গায় যেখানে অন্যান্য জায়গায় যে ছাপানো হয়েছে, আমার মনে হয় তারা ঠিক এই জিনিসটা অতটা জানতো না, নাহলে নর্মালি ছাপা হওয়ার কথা না। কারণ একটা জার্নালে ধরেন হলো আমাদের NIMH এর যে আর্কাইভ, সেখানে একটা জিনিস ছাপানো হয়েছে, সেটা আমার জার্নালে আবার ছাপানো হচ্ছে। আমি কিন্তু এক্সিকিউটিভ এডিটর হিসেবে আমি কন্ট্রোভার্সির মধ্যে পড়ে যাব। কারণ হলো আমি যেখানে আরেকটা ছাপানো হয়েছে সেখানে আমি কিন্তু ছাপাতে পারি না। ইভেন আমরা যে পত্রিকায় লিখি, আমি একটা প্রথম আলোতে লিখলাম, সেই লেখাটা কিন্তু হুবহু আমাদের সময় বা আমাদের বাংলাদেশ প্রতিদিন লিখতে পারবে না। অনেক সময় এই ধরনের জিনিসগুলো ঘটে, অনেক সময় অথররা ঠিক মতো করে জানে না, যেটা আপনার ক্ষেত্রে হয়েছে যে অথররা জানে না, ওরা এটা করে দেয়। কিন্তু অ্যাজ এ জার্নালিজমের পার্সপেক্টিভ হিসেবে এবং হলো পাবলিকেশনের পার্সপেক্টিভে এটা টোটালি আনএথিক্যাল। কাজে আমি বলবো হলো যে এবং এই জায়গায় আপনিও কিন্তু পরবর্তীকালে হয়তোবা আপনি কিন্তু হয়তোবা একটা না অন্য জায়গায় ছাপাই দিছে, এটা এইভাবে কিন্তু তারা করতে পারে না। যতই সে বলুক, এখানে যেহেতু ব্রিটিশ জার্নাল অফ সাইকিয়াট্রিতে এটা ওদেরই হলো কপিরাইট, ওদেরই কিন্তু এখন হলো যখনই আপনি একটা জায়গায় ছেপে দিবেন সেখানে কিন্তু তাদের অধিকার, এরপরে কিন্তু এটা আর করতে পারবে না। তাহলে তার আমার ক্রেডিবিলিটি থাকলো না। একই জিনিস যদি আমিও পড়ি আরেকজনও পড়ি, তাহলে এটা তো আমার জার্নালে যখন দিচ্ছেন তখন এটা কিন্তু আমার অধিকার, এটা হ্যাঁ আমার জিনিস। তখন আমার জিনিস যখন আরেক জায়গায় ছাপাবে, এটা কখনোই হলো কোনো পাবলিশার এটা করতে দিবে না, এবং এটা তখন কিন্তু লেখক এবং পাবলিশার এটা দুজনেরই মধ্যে কন্ট্রোভার্সির মধ্যে চলে যাবে। তবে অনেক ক্ষেত্রে আমরা না জেনে এই জায়গাগুলো অনেক ক্ষেত্রে করে ফেলি। তা আমি বলবো হলো যে ইয়াংস্টারদের এই ব্যাপারে আরো মনোযোগী হতে বা আরো এই জায়গায় সচেতন হতে। ধন্যবাদ সকলকে। তবে আপনার প্রেজেন্টেশনটা খুবই ভালো, এটা ডেফিনেটলি হলো এটা সবাই আমাদের জানবে, এবং এটা তো অবশ্যই একটা কেস রিপোর্ট, এটা আমাদের অনেক রকমের চিন্তার দেয়। এটা ডেফিনেটলি ইটস এ ভেরি গুড তা আমি খুবই খুশি হতাম যদি প্রথম হলো আর্টিকেলটা আমার হাতে আসতো, আমার জার্নালে ছাপানো হতো। থ্যাংক ইউ ভেরি মাচ।
থ্যাংক ইউ। আমি এই প্রসঙ্গে মানে ছোট্ট করে আরেকটা বলি, আমাদের বাংলাদেশে একজন সাইকিয়াট্রিস্ট কম বয়সী অস্ট্রেলিয়ান, তার একটা এরকম জার্নাল সে 2 জায়গায় ছাপানোর জন্য তার প্র্যাকটিসিং রেজিস্ট্রেশন বন্ধ হয়ে তাকে দেশে পাঠিয়ে দিয়েছিল। হ্যাঁ, থ্যাংক ইউ।
Thank you, respected sir and ma'am, for your nice conversation. Now, I would like to request our teacher, our mentor, Brigadier General Professor M. Kamrul Hassan sir, to say some few words about the overall presentation session.
হাসান, সরি, আমি কামরুল স্যার পরে বলুক, আমি ছোট্ট করে আগে বলি। স্যার সিনিয়র, হ্যাঁ উনি পরে বলেন। আমি ছোট্ট করে একটুখানি বলি, আমি অলমোস্ট বলে ফেলছি। ডক্টর এনামের প্রেজেন্টেশন রিয়েলি সুন্দর ছিল, অন্তত খুব ইজি ছিল। আর আমি আবার সেই কোশ্চেন চলে আসে আমাদের টুম্পার কাছে। টুম্পা, যদি এটা মানে ওসিডি, কারণ যেহেতু স্টিলিং, আমরা বলছি স্টিলিং কিন্তু আবার স্টিলিং না, সে তোমার শব্দটা ছিল যে সে পিক করে এরকম কি একটা শব্দ ছিল, পিক আপ এরকম একটা শব্দ ছিল। তো হোয়াই ইট ইজ নট ক্লেপ্টোমেনিয়া?
এখানে ডিফারেন্সিয়াল ডায়াগনোসিস আমি দেখিয়েছিলাম যে ক্লেপ্টোমেনিয়াটা আমরা কিভাবে এক্সপ্লোর করছি। ওখানে ওর যেটা হতো স্যার, বিফোর পিক আপেও সে একটা ডিস্ট্রেস ফিল করতো এবং পিক আপ করার পরেও একটা ডিস্ট্রেস ফিল করতো, ও কোনো গ্রেটিফিকেশন হতো না। ক্লেপ্টোমেনিয়াতে স্যার যেটা হয়, একটা করার পরে তার একটা গ্রেটিফিকেশন বা প্লেজারে আসে, ওর হচ্ছে যেটা হতো
না। ক্লেপ্টোমেনিয়াতে আগে তার পিক আপ বা চুরি করা বন্ধ করার জন্য সে আর্জ ফিল করে, এবং সে নিজেকে মানে কি বলবো যে এখান থেকে উঠানোর জন্য সে অনেক রকমের অনেক কিছু করে। ক্লেপ্টোমেনিয়াতে কিন্তু সেই একই রকমের এজিটেশন হয়, স্ট্রেস হয়। এমনকি তুমি যে বলছো যে পকেট ছিল না, পকেট রাখতো না যাতে সে এইরকম কাজটা করে, ক্লেপ্টোমেনিয়াতে কিন্তু এটা হয় যে ওই জায়গায় গেলে আমি এই কাজটা করে ফেলতে পারি এই ইম্পালসের জন্য, তখন সে ওই জায়গাটা পর্যন্ত অ্যাভয়েড করে। আমার মনে হয় যে এটা ডায়াগনোসিসটা আমার
স্যার এখানে ওর আরেকটা যেটা হতো যে এমইসিতে যেটা যে ওর খুব মানে অবসেসিভ থট যেটা, এটা কিন্তু খুব বেশি হতো, প্রিডমিনেন্টলি হতো, যেটা ক্লেপ্টোমেনিয়াতে তো স্যার এরকম অবসেসিভ থট হতো না, যেটা এই বাচ্চাটার ক্ষেত্রে ছিল, মানে অবসেশনটা খুব প্রিডমিনেন্ট ছিল।
থ্যাংক ইউ। এটা আমার একটা কোশ্চেন রয়ে গেল। ওর প্রেজেন্টেশনটাও সুন্দর ছিল। সুমাইয়ার প্রেজেন্টেশনটা ডেফিনেটলি অত্যন্ত গুরুত্বপূর্ণ আমাদের পরবর্তী সাইকিয়াট্রি বা মেন্টাল হেলথের মানে বিভিন্ন পার্সপেক্টিভের দিক থেকে। দ্যাট ওয়াজ এ নাইস প্রেজেন্টেশন। অ্যান্ড লাস্ট ওয়ান, আরিফ, his presentation was also fine. Normally obsessive compulsive personality disorder আমরা সত্যিকার অর্থেই এখনো ওইভাবে ক্লিনিক্যালি খুব বেশি ডায়াগনোসিস করা হয় না, খুব কম করা হয়। তো সেই ক্ষেত্রে ডায়াগনোসিসটা করা এবং প্রপারলি ম্যানেজমেন্টের যে ডিফিকাল্টিসগুলোকে আইডেন্টিফাই করে সেটাকে রিজলভ করার চেষ্টা করা, ডেফিনেটলি ওটা ওয়াজ ফাইন। অ্যান্ড তোমার প্রেজেন্টেশনও ভালো ছিল। থ্যাংক ইউ আমার দিক থেকে একটু।
Thank you very much. Now I would like to invite Brigadier General Professor M. Kamrul Hassan sir to say some few words.
Thank you very much. Probably everybody is tired. We heard 3 case reports and 1 study presentation. And definitely 2 of the case reports were unusual, but not that much difficult to diagnose, especially the first one, though it is really very much unusual. The second one, which was presented by Dr. Tumba, and question was asked by Professor one of our colleague, that why it's not a case of kleptomania. So I think here the ego-syntonic and ego-dystonic matter will come. And if it is a case of OCD, it must be ego-dystonic. So we should ask the person. And if it is ego-dystonic, then it should be OCD. Now, I have nothing to say about the Suicide Bangla movie and drama, but most of the cases we found that nowadays, more or less, the authors or the directors, they used to contact with different psychiatrists before they portrayed the pictures in their drama. But previously it was not done. The way it was portrayed, it was fully deviated from the actual one, which impacts was very much negative to the society. Now, third one, the management difficulties in a patient with OCPD, presented by Dr. Arifuzzaman. Here, the main distinguishing point why it is very much difficult to treat, that OCPD is ego-syntonic. So they don't think that it's a disease, and thereby they are very much unwilling to be treated. And most of the OCPD patient is resistant to treatment. So here, that's why the patient was taken to the hospital against his wish forcefully. And the OCD diagnosis may be very much usual and maybe unusual. I found a case in our hospital where a Dhaka University student was not communicating with his mother for last 5 years. And she used to hatred overtly his mother. He did not go home to see his mother for last 5 years, and when his mother came to visit his hall, he left the hall. And he was admitted to our hospital by his parents, why it is happening, why he can't actually see or like his mother. Finally, when I saw him, he was admitted for the third time. And what I find that when I ask him why you are not seeing your mother, he said that he thinks if he goes to his home, he will have intercourse with his mother. That's why he was avoiding his mother. He do not talk. Even when he talks, he is thinking that he is actually about sexual urges comes out in his mind. So he stopped talking with his mother. So OCD is such, and it is very much common. And these are typical presentation OCD are misdiagnosed, and thereby they are very much remains in the society as an untreated condition. Thank you very much. Every presentation was good and fruitful. Thank you very much.
Thank you, sir. Thank you very much. We are running out of our time. Now this is the time for crest giving ceremony. I would like to invite at first Dr. Muhammad Said Inam sir to collect his crest from our respected Kamrul sir. Now I would like to invite Dr. Tumpa Indrani Ghosh to come on a stage, and I am requesting our Biplop sir to hand over the crest to Dr. Tumpa Indrani Ghosh. Now I would like to invite Dr. Sumaya Binte Jalil to come on stage, and I am requesting our respected Kamrul sir to hand over the crest to Dr. Sumaya Binte Jalil. Now I would like to invite our last presenter, Dr. Muhammad Arifuzzaman, to come on stage, and I am requesting our respected dear Dr. MMA Salahuddin Kausar Biplop sir to hand over the crest to Dr. Muhammad Arifuzzaman. Now I would like to invite our great teacher and great mentor, Brigadier General retired, Professor Dr. Muhammad Azizul Islam sir, to come on stage and hand over the crest to our respected teacher, Professor MMA Salahuddin Kausar Biplop sir. Yes, sir. At last, I'd like to request our great teacher and great mentor, retired Professor Dr. Farooq Alam sir, ex-director, National Institute of Mental Health, to hand over the crest to our respected teacher and mentor, Brigadier General Professor M. Kamrul Hasan sir. Thank you very much, respected audiences. Thank you very much. Thank you very much to our great to mentor and teacher and today's chair. Thank you very much to our presenters. Now, at the end of the oral presentation 3A session, I would like to invite our two chairs, our presenters, for a good picture on a stage. Please, sir. And after that, the session will be ended, and at 7 p.m., our next session is the inaugural ceremony, and everyone is requested to ensure your presence at inaugural ceremony. I would like to request our teachers to come on stage and our presenters as well for a group photo. I would like to request dear Mekhola ma'am to come on stage for a group picture. Ma'am, if you permit. Thank you very much. This is the end of our session. Thank you, dear respected audiences.